Good morning, everybody. Happy Saturday. So, I am trying something new today, and I've set up a little bit of a new studio here. I'm using StreamYard and wanting to see if I can go live on multiple platforms. So, we have LinkedIn, Facebook, and YouTube currently through StreamYard. And then with TikTok, I'm directly live. So, might be a few bumps today, specifically on TikTok, because I'm not exactly sure when I share my screen, because I want to talk a little bit about Medicare Advantage, the MedPAC article that came out a week or two ago, discussing how Medicare Advantage is going to be more expensive per enrollee. Yet we see earlier this week that the federal administration is at least toying with, proposing the idea of moving all Medicare beneficiaries into Medicare Advantage. So that's kind of the antithetical approach to what at least the MedPAC article had to say. So once again, if you're just hopping on, bear with me as I've got the new setup, the new studio, and seeing if we can at least have a little bit of fun and talk some Medicare Advantage. So if you are on with me and you can see me and you can hear me, please feel free to interact. Feel free to chat, drop a comment, ask a question, because I'm trying to figure all this stuff out. So appreciate y'all. All right. So first up, let's see what we got here. We have, let's go to the MedPAC article. For those of you who aren't familiar with MedPAC, it is the Medicare Payment Advisory Commission. And they, do some overview of Medicare and dive into the weeds. Let me see if I can get that article up on screen here to share it with you. And let's do a screen share and let's see here. Let's do a window and let's do the MedPAC article. There we go. We should be, if you're with me on LinkedIn, YouTube, or Facebook, you should, now that I'm going to add it to the stage, boom, you should see the MedPAC article. All right. So let's review this guy together for a second. So once again, the main tag, and forgive me if you're on YouTube, or excuse me, if you're on TikTok, you're not going to be able to see this, but if you're on with me on LinkedIn or YouTube or Facebook, you are. So check this out. Let's see what article this is from. This is from Fierce Health. And the title of the article is "The Feds Will Overpay Medicare Advantage Plans by $76 billion this year," MedPAC estimates. This was released on March 13th, 2026. So what is MedPAC? The Medicare Payment Advisory Commission, interesting, released its March report. They released it to Congress, where it also weighed in on annual payment changes for providers. So there's been a lot of changes in Medicare payment, announced over the past couple of months. The federal government announced that for 2027, because they've already implemented the 2026 fee schedule, but that in 2027, they're only going to increase the fee schedule by 0.9%. Most companies, if you followed what United Healthcare and Centene and some of these other really big healthcare companies that have Medicare books of business, Medicare Advantage books of business, they've lost market share. They've lost their value because the increase wasn't what they thought it was going to be. I think most folks thought between a 4 to 5% increase because of inflation and the cost and everything else continuing to go up. The federal government said, no, we're going to do a 0.9 adjusted for inflation. That's a loss. That's a haircut. So those companies' value went down a bit. But what I think is interesting here about this article, and let's see if I can give you guys a better, I guess it's probably better if I stay. Oh, there we go. We'll be in screen. What's interesting about this is if you dive deep into what MedPAC did here, they really only focused on one aspect of what Medicare Advantage does. And, for those of you who, haven't interacted with one another, I've worked in healthcare for the past 20 years. In fact, going beyond that, my grandfather was an orthopedic surgeon. My grandmother was a nurse. My uncle is a trained orthopedic surgeon. He's retired now at this point, and my mom was a nurse. Doesn't mean that all of that's passed on to me, but the conversations around the dinner table were always healthcare related. I went to school, got my undergrad in health science, and then later on a master's in business. I'm kind of one of the knuckleheads in the family that didn't go the clinical route, so to speak. But I say all that because my entire career I've worked in healthcare in different settings. Behavioral health, which was an amazing experience, got to see a whole different avenue of that. A lot of the Medicaid business in the behavioral health side. Moved into kind of the back office functions, if you will, within the broader healthcare space. Have bounced around in business segments. Also oversaw adult primary care, pediatrics from a traditional operational standpoint in a large healthcare setting. I've worked for national, private, for-profit, nonprofit settings, and a lot of it's been with the Medicare Advantage space. And you know, when I see articles like this, it tends to increase some of those red flag warnings for me and go, is this a political angle? We won't have to dive into that today. But generally speaking, I like to think about it because why are currently over 50% of the Medicare beneficiaries are enrolled in a Medicare Advantage plan. And every year around annual enrollment period, a lot of, for and against media comes out. A lot of the people for Medicare Advantage come out and say, hey, these are all the benefits you get. Obviously the health insurance companies, are marketing it and want to grow. And then on the flip side, you have a lot of folks saying how bad it is. You have exclusive networks and, this is just a big shift. And I think seniors get confused. But with this, historically, patients who have Medicare Advantage are twice as likely to get preventative medicine. They are less likely to be admitted to the hospital. If and when they are admitted to the hospital, they're usually discharged. I think this is old stats, but on average, a day earlier because they have a care team and more likely to get back in to see their primary care and a referral into their specialist to help manage some of these, generally speaking, chronic conditions and decrease costs. So when I see an article like MedPAC that says, and once again, the tagline here is Medicare or the government will pay 76 billion more for individuals enrolled in Medicare Advantage than it would have for enrollees in the traditional program. That brings a little bit of interest for me. So let's dive into what exactly they say it's from. Now, the coding intensity, this is where they're coming. This is exactly where MedPAC is going with it. Coding intensity, meanwhile, reflects the likelihood that more diagnostic codes are recorded for MA enrollees. What does that mean? If you're jumping in on YouTube or Facebook and you don't have a healthcare background, if you don't work in healthcare, you're probably not going to understand what that means. Coding in this context means when a physician or a provider sees a patient, they review their symptoms, etc. And there's a diagnostic code for pretty much everything a physician does. It paints a picture of what we call acuity or how sick or maybe in need of care a member is. And coding is the way that we describe that, right? It's kind of how they paint the picture. Now, in the Medicare Advantage space, Medicare has a system called risk adjustment, and each code based on what a lot of actuaries and health professionals have decided over the years describe how sick somebody is based on these codes, right? So if you have diabetes and heart disease and COPD and all this stuff, there's a numeric factor that gets applied because when a doctor codes a patient and they have these conditions, they send the codes back to Medicare, and it basically tells Medicare how chronically ill these people are. And that picture then tells Medicare how much more money or how much money should be spent on providing care for these members. And if you're just joining, I appreciate you guys. I'm just going live for the first time. I'm kind of on multiple platforms. So if you don't mind dropping a comment, tell me where you're at. I'm on Facebook, LinkedIn, YouTube. We're talking about Medicare Advantage. We're kind of covering the MedPAC article that was released earlier this month and talks about how much more expensive they project Medicare Advantage to be over Medicare. So if that's an interesting topic to you, hang out. I know it's Saturday, depending on where you're at, hang out with me and talk through this. But we're just kind of talking about what coding is and upcoding and specifically what this article is highlighting as coding intensity. If you guys can see my screen, Um, so at the end of the day, in Medicare Advantage, we, if you will, as the folks that manage these members, get the ability to paint a picture of how chronically ill these members are, send it back to the government and say, hey, it's going to cost us a little bit more money. So they give you a bump on what's called capitation, or the monthly payment that the federal government passes down through the health plans and then down to the medical groups and doctors that are managing these members. And that is what MedPAC here is saying is going to be super expensive. Hey, this upcoding is really going to break the bank. We're going to spend $76 billion more, as the article says here. And Pat Landry on TikTok, I appreciate you joining. I'm on StreamYard with 3 other platforms, and I couldn't add TikTok. So forgive me, I can't share the article with you. But if you're listening along, I just want you to know I appreciate you joining in. And we're going to keep it rolling here with this article. But so to continue with the article, they're saying that the higher payouts are borne by taxpayers. So obviously Medicare, Medicaid, taxpayer driven. And as we pay more into the pot, and if these members are at least documented in coding, more expensive up front, it's going to cost more. So, what MedPAC is saying is MA plans will be paid an additional $2,600 each year in rebates. And, an average of 19% is estimated to enhance the Part D. So the drug, 7% to reduce Part B premiums, which is the outpatient part. Part A is hospital. Part B is the doctor outpatient, and Part D is the drug. And they continue to kind of go on and describe, how basically they justify their existence. MedPAC says we exist to provide Congress with an independent assessment of the Medicare program. Now, okay, I'm going to park this MedPAC article for a second, because I think it's also important to understand coding is the front end. Coding is the way physicians document how chronically ill a patient is. They send that to Medicare. Now, the whole purpose of Medicare Advantage is in an HMO, a health maintenance organization. Now, I'm not saying I'm for or against it. I'm just describing it here. An HMO within the senior context, forget about the commercial age folks, forget about any pediatrics, forget about any of that other stuff. Within the senior space, the Medicare Advantage plans are heavily regulated on what they need to provide to these members and make sure they have access to care and that they're getting everything they need. The benefit to both the member and the system is that there's a defined network. Members can only see physicians that are in their network. That's the purpose of an HMO. And the idea is that they continue to maintain that. And Zuzu, if you just joined, I appreciate you jumping in on TikTok here. I'm going live for the first time, and I'm on StreamYard on 3 other platforms, but I couldn't figure out how to connect it to TikTok. So you can't see the article that I'm sharing, but I'm looking at a MedPAC article that talks about the cost to the federal government for Medicare Advantage members. So if you're into healthcare and some of the weeds on these healthcare senior topics, we're diving in. And I was just getting to the point of the benefits of an HMO and why, folks are in these networks and how they work. And if you're joining on the other platforms, thank you for stopping in. Even if it's just for a second, we're reviewing the MedPAC article that talks about Medicare Advantage costs. So long story short, this article really went over the front end cost of coding, the increase that'll have to, the tax dollars, but it doesn't cover the benefits. And so what I'm going to do is actually remove this article here if you're following with me. And I'm actually going to pull up another article that I think is kind of interesting. Maybe you've seen it, maybe you haven't. But the federal government just said, hey, we're thinking of auto-enrolling every person that's a senior into Medicare Advantage. So instead of traditional Medicare, you will be auto-enrolled into, let's see here. I gotta add a new window here. And once you get on TikTok, I appreciate you guys just hanging out while I go through this on the other platform. I'll figure it out, and then maybe next time I'll be able to display it on here as well. So I'm going to share a window with this automatic enrollment. So remember, first article was MedPAC talking about why Medicare Advantage spend is going to be higher. But now the federal government comes out. Now this is a justice and aging article, and TikTok, once again, you can't see, but The federal government saying automatic enrollment in Medicare Advantage plans under consideration. Top Trump health officials say. So if you love Trump, if you hate Trump, this is what they're talking about. President Trump's Medicare director said Thursday his team is considering a policy that would automatically enroll Medicare beneficiaries into Medicare Advantage plans, a controversial idea that was touted in the conservative Project 2025 policy blueprint. Now, why? Could it just be corporate greed? Is Trump just wanting to line the pockets of his friends, potentially in these corporate situations? Maybe that's it. But I'll tell you this, throughout history with the Medicare Advantage, members get access to preventative care faster. They have a care team that wraps around and helps make sure they get access to things like colorectal screening, breast cancer screening, blood pressure testing, A1C testing, all of the things that we consider in the quality of care world. Medicare Advantage members get. Traditional Medicare beneficiaries don't get those to the same degree, right? It really requires the PCP and even the member advocating for themselves to go get these services. So in Medicare Advantage, they have this care team, and there's a health plan, and there's an IPA or a medical group or a system that's really focused on helping these members get access to preventative care, which leads me to my point, and possibly, I don't know, but possibly why this article would lead people to think that there's a benefit of going into Medicare Advantage, which is the cost savings on the back end. Meaning, yes, MedPAC highlighted that the front end, there's going to be some expense to Medicare Advantage because of the coding. And I don't even want to say upcoding, but maybe it's an accurate code, right? Now, one thing that's not highlighted in either article, neither the Justice for Aging or Justice in Aging article, nor the MedPAC article, do they talk about the cost savings of Medicare Advantage. So think about it like this. The intent of coding these people is to, and Jonathan on TikTok, I see you've joined. I don't know if you're still there. If you have, I appreciate you. I'm online with a few other StreamYard platforms through StreamYard, and I couldn't connect TikTok. So you're not seeing what I'm putting up. But if you have any questions, please feel free to drop one in. I'll be happy to answer it. But once again, no discussion of the cost savings through Medicare Advantage. Now, as we go into this article, now, once again, this is, let's see here. We're going to get over to not the MedPAC article, but we want the Justice and Aging article. It's a really brief article. They basically just say, hey, we're considering and concerned about getting folks into, here we go. Here's another stat article. Let's see if we can get out of all this stuff here. Automatic enrollment in Medicare Advantage plans under consideration, they say. Chris Klomp said the Center for Medicare and Medicaid Services is mulling the feasibility of models that would either automatically enroll beneficiaries into the private form of Medicare or accountable care organizations, which we can unpack an accountable care organization. And if you're joining on TikTok, or if you're joining on any of the platforms, I'm through StreamYard here, and we're talking about Medicare Advantage. It's a live test. Thank you for joining. I know it's Saturday. I'm not sure if you are in my network here on LinkedIn or Facebook, YouTube, but nonetheless, thanks for popping in. And we'll continue with this review here. But the point is, Medicare shared savings programs, ACOs, and MA tend to save the system money. Yet the MedPAC article said it doesn't. So I wonder what the federal government's seeing that the MedPAC folks aren't seeing. Why is the federal administration wanting to put folks into these Medicare Advantage or shared savings or ACO settings? And I think it's because there's a flat dollar that they pay. The federal government pays the health plans a flat dollar. It's called capitation. Yes, some of it can be adjusted up based on the risk factors. We've talked about that. But the back end, if we save, the whole point of all these coding initiatives, and I've dragged it out to the longest point here, the whole point of doing all of the coding is to prevent the hospital admission. Hospitals by far are the biggest expense to the patient in the healthcare system. And the events can cost tens of thousands to hundreds of thousands of dollars, depending on how long they stay. And if a person is on a Medicare Advantage plan, or they are in an accountable care organization, or they are in some type of a shared savings plan, the federal government is basically protected from that expensive or increasingly expensive event because they've already given the risk over to a health plan. So let's say it costs the federal government $20,000 a year to manage these members on average, and they can give that risk over to a health plan for $18,000 a year, and the health plan can manage the member at 15. Then they get a little bit of profit, right? Up to the 85% medical loss ratio that they get. But if the health plan or the ACO or the shared savings plan loses money, the federal government doesn't. So they're protected, right? That's what the federal government is looking at here. How do we basically put a limit on our loss, stop loss, right? And one way the federal government does that is by um, putting, Medicare Advantage in place, or Medicare ACOs, shared savings plans, and the like. So I think that's what the take is here. Um, I don't know if what's going to happen, but I think they're toying with the idea of putting people into these Medicare Advantage plans, and I would love to see the reaction of people at large, because it tends to become a very political event very, very soon, and that's always kind of fun to watch, because some people just play their politics and want to blame everything on one side, and things could change. And all of a sudden it's like George Orwell in 1985, and, the thought police are coming, and depending on the direction we go, we change it. But at the end of the day, we have to look at ways to cut expenses. Okay. Now, what else? What else should we look at here? I think earlier this week, there was some fun stuff that came out about GLP-1s. And I'd love to talk a little bit about those GLP-1s. Let's see if I can get up some good articles about GLP-1s. I think 57 million Americans, working Americans. Let me see if I can pull up this article, because I'd love to share it with you guys. And if you're just joining on either LinkedIn, Facebook, or YouTube, I appreciate you going live for the first time, trying out a new set, brand new to me because it's the first time, but StreamYard, which is a platform where you can go multi-platform. So if you're seeing this, talking about Medicare Advantage, going to pivot actually a little bit over to a GLP-1, so Ozempic kind of discussion, and see if we can't have some fun with that. But there was a recent article that said that 57 million Americans were eligible for a GLP-1. 57 million working Americans was eligible for a GLP-1. And that is kind of alarming, because the criteria for that means basically, let's see here. The criteria for that is obesity, diabetes, and a few other things. But let me see if I can get the article up on screen for you. And if you have any questions or comments, you can drop it in. I'll be able to see it. Would love to see if you guys can see and hear me okay. If you can't, that's a bummer. Let me find this article here. March 2026 is the one right here. Let's see. Newest GLP-1 article, 57 million Americans. Happy Saturday, by the way. Okay. 4%. I need the link. 57 million headline. Here we go. Let's do this. Okay, March 26th. Let me see if you're still hanging in there with me. Let me share this for you. I need to stop the screen. Boom, add the new one. Screen share window, and we're going to go with bam. Here we go. We should be live right now. Boom. Talk to me. You guys see it? Screen in screen. Okay, here we go. Check this out. So this is an article from the Parrot Benefit Group, and many people have come out with these articles the last couple of days because it's such a big deal. And if you've joined on TikTok, thank you, JN Booby24. I'm not able to share my screen on TikTok because I'm on StreamYard, And forgive me, but thank you for joining in. Okay. GLP-1 cost benefit analysis. Over the past several years, glucagon-like peptide, GLP-1 medications such as Wegovy, Zepbound, of course, Ozempic, have reshaped metabolic care. These drugs were originally developed for type 2 diabetes, but now, when paired with diet and exercise, they are widely used for weight management, generating both curiosity and concern among employers and plan sponsors. Why? We see it in the media. We see, they call it the Ozempic look. We're seeing Serena Williams. We see the, the ads. But now they're talking about employers and plan sponsors. That's not just, your cosmetic folks in the media. This is big time now, right? Why would employers be concerned? Let's talk about it. With employee interest rising and clinical evidence expanding, many organizations are trying to determine whether offering these GLP-1s is worth the substantial and growing cost. We know they're expensive, right? I don't know if any of you guys have tried to take a look and see, but sometimes they're thousands of dollars. Let's dive in. And 1 in 5 companies, so 19% with 200 or more workers, and this is according to the Kaiser Family Foundation, 200 or more workers and 43% of firms with 5,000 or more workers cover the GLP-1 drug in 2025. Now, the growing demand, and let's see if we can't get to the broader concern here. The drugs have gained rapid popularity from plan participants eager to lose weight and improve their overall health. Mounjaro, Ozempic, and I don't even know how to pronounce that, Rybelsus, are approved for treating type 2 diabetes, but are commonly prescribed off-label for weight loss. Interesting. Okay. The demand is growing at a rapid pace. 12% of Americans have used, a recent RAND report revealed that 12% of Americans have used a GLP-1. That's interesting. Wow, 12% of Americans. Whoa, that's a big number. What is that? What is 12%? So 12, 24, 30. I mean, if we have 330, that's like maybe 40 million Americans. That's crazy. Here we go. Furthermore, according to the Kaiser Family Foundation, more than 57 million privately insured adults, over 40% of those with employer-sponsored coverage, meet clinical eligibility for a GLP-1 medication based on diagnosis of obesity, type 2 diabetes, or overweight status with additional risk factors. Despite this, fewer than 1 in 5 employers with over 200 employees currently cover GLP-1s for weight loss purposes, even as employee interest continues to climb. Holy Toledo. 57 million privately insured adults are eligible. 57 million privately assured adults. How many adults do we have that are even in the working class? How many American adults over 18, I'm looking at Gemini here currently, are in the workforce? Interesting. 57 million. It's got to be a lot, because to take out the seniors, what do we have here? 170 million. So 57. That's basically a little less than a third. Is that right? It should be around there. Yeah, 33.5. Okay, right on. Oh my gosh. A third of the American workforce is eligible for a GLP-1. Forget about the cost to the employer. Why do we have so many people that are eligible? That means they meet the criteria. Let's go over the criteria one more time. Listen, the criteria here is diabetes, obesity, overweight. 1 in 5 cover. That's bananas. That's bananas. So the financial cost is about $1,000 per month without insurance. Now, some GLP-1s have as low as a $25 copayment, which is great. I guess we could look at it in a couple of ways. A third of our adult American workforce meets the criteria, which it boggles my mind, because it needs to happen at home, right? I mean, healthcare starts at home. We know it starts at home. It starts with what you eat, starts with how you move, starts with what you do. But forget that for a moment. If we know that the biggest expense to the American taxpayer and the healthcare system in general is based on chronic disease, maybe we should start covering these GLP-1s. Maybe we'd have better health outcomes if we covered more of them. right? Folks don't seem to want to eat better. Folks don't want to work out. Folks don't want to have, a little bit less stress. They want the magic pill. Seems like this is the right way to go. What's the downside? Is there going to be a downside to this? Are we going to have, are we going to be in a situation where nobody takes personal accountability anymore? And folks just want to have the magic pill, which seems to be these peptides. I think that's where we're going. And it's kind of scary to me. I'm going to remove this now. It's kind of scary to me that we as a society are more interested in the cost of these drugs, the employer's looking at. If I'm an employer, I'd probably start doing it. Why wouldn't I? If I'm an employer and a third of my workforce is obese and I cover this at $1,000 a month, a 12-week program, who knows how long they can be on it for, I'd probably cover it because it's going to decrease the risk of all the other downsides that happen with the chronic disease pathway, right? I mean, 4 out of the $5 trillion that we spend on in healthcare, and that's not just the government spend, that's all payers. It can be traced back to chronic disease. And of course, it presents differently, right? That's the medication spend, that's the physician spend, that's the hospital admission spend, those are the surgeries, it's the dialysis, it's all of the things that add up to create that spend. But if we could reduce that up front for $1,000 a month, it's going to decrease tens of thousands of dollars on the backside. The problem is, do people have to stay on this for life? Do you have to stay on a GLP-1 for life to get the benefit? And then what happens to bone density? What happens to muscles? I've heard, and I can't find, haven't even looked, but I could probably find the article where they're adding other peptides to the GLP-1s that help maintain muscle mass. So is that it? Is that the magic pill? We can eat whatever we want. We don't have to exercise and we can just take these peptides. Is that the solution? Just no accountability, tax people through the roof, give them these medications, eat like junk, don't move. Maybe that's the solution. Maybe that's what we'll end up doing. But either way, if you've joined today with me, regardless of if you were on TikTok for, a couple minutes and you couldn't see, or if you were on any of these other platforms, I appreciate you joining. Thank you so much for stopping in. I'll probably continue to do more of these. I'll probably schedule some of these out in the future, and we'll keep the ball rolling. So thanks again. Talk to you next time.